So for the planning of the event, I believe that this would be very interesting, because when we plan image and all the aspects we need to perform this procedure is completely related to what we are discussing. My presentation, please. As I said, we will talk about transarterial radiotherapy for primary tumors and secondary hepatic malignancies. I will also present a video to show how the procedure is carried out. We usually have a catheterism of an artery that can be upper limb or femoral artery, and through the catheterism we study all the liver branches. Here you can see the tumors, and the liver is fed by two arterial and portal, and here the lesions are fed by the branches. Then we have the catheterism of the hepatic artery. We introduce the catheter, and the radiative spheres are introduced in the tumor, and they remain there and issuing radiation to destroy the tumor lesion. So basically, this is the access we have to place the radiation. Here we are carrying out the procedure at Hospital Israelita Albert Einstein. This is a cage where we receive the radiative material. We prepare the room and the doctors, because we cannot be exposed to radiation. The spheres are within the vial, and then the catheter is positioned within the arterial branch, as in the video I showed you, and the spheres are pushed through this syringe and introduced. A needle is introduced in the vial. The spheres are injected, and so we place all the spheres calculated with the dose activity for the tumoral lesion. So this is an X-ray with a very big tumor, and we have to plan. We need a volumetry, as you can see in the upper image, and also dynamic volumetry that we carry out during the surgery with a catheter placed in the branch of the lesion. The 4D tomography will help us a lot with this image and calculate the volumetry to compare to what we calculated before in the radiology department. And this is the last image, the PET-CT, showing the spheres within the tumor, and they will issue radiation and treat the tumoral lesion, and the patient will have an image follow-up, so we can see how the tumor behaved with the treatment. This is what I had to present. It's absolutely revolutionary. I will just remind you that those who are watching us, you can send your questions through the chat, and our experts will answer 2 questions of each topic. So now we will have the comments by Marcos Menezes. He is the head of Percutaneous and Syrio-Lebanese Hospital. You are expert on oncology. This technique is not exactly in your area, but what do you think of this technology as complementary or a competition? The technology Felipe just showed, radioembolization is here to stay with great benefits, especially for advanced disease, for the control in hepatic advanced disease. So this I see in our daily practice, and the gain for the patients in terms of controlling the disease. But what can 4DCT provide? I believe this is more or less what you said. This technology came, and we are still just exploring that. So what we see in face of this new technology is that it opens opportunities that we are still unaware, and we don't know how to use. Some classic and obvious procedures that were shown that I associate to procedures that I have to do separately. Something that will need embolization and ablation I would do in 2 times, and now it will be in a single procedure without having to displace the patient and optimizing flow and room. This is the obvious gain. Another gain is maybe in terms of safety. For instance, if I need a biopsy or ablation in a very critical area with a risk of bleeding, I may place the catheter, leave it there, and carry out the procedure. And if I have bleeding, I can stop it immediately. This is a possibility that is very strong for you, the use of this technology, and open other possibilities. As we saw in the lecture by Dr. Garnon, we will leave our limits and expand the limits in procedures that were very risky, and due to the risk, I wouldn't perform. And now I have more precision to perform them. So for radioembolization, we'll probably find things. So before Felipe commenting, radioembolization is a very efficient technique because it destroys tumors, big tumors, but it has to be very precise, because if it goes to a non-tumor area, it can produce damage. So if you just inject and you have a CT, you will see that that branch will feed the stomach or the esophagus. The two comments are very important, Marcus and yours. Our concern is always that we have to identify the vascular branches, and when fluoroscopy we have angiographic acquisition, we believe that the anatomy is designed by, but the CT allows us to foresee that it is exactly that structure. So we avoid injecting spheres in a non-target organ or non-target area. And this, with this, we are faster. We can have the angio within the surgery, the contrast, compare volumetries, and plan. So the two aspects are very important. Carnevali, I believe you also have experience in your service. Would you like to add anything? Yes. And I would like to hear the opinion of Dr. Nasser, because the development of these techniques, especially for radioembolization, are increasingly we have patients that are candidates that were submitted to hepatic or renal embolization, and large tumors that were treated with other techniques that are referred to the interventional radiology. And we have to carry out diagnostics, that is the mapping, the first stage, and we identify in some situations what we call parasitic arteries or parasitic circulation. Felipe, do you believe that there is a role for this new technology in identifying this parasite circulation so we can achieve the focus, which is the lesion?
I believe so, and many times when we prepare the patient for vascular access, we took a look at the CT, diagnostic radiology, so we can talk to everyone and see what the anatomy is. And intra-op, injecting contrasts straight into the region, we can plan and find those parasite branches that you mentioned. Another thing that I'd like to mention is different, which is the lobectomy and segmentectomy and radioembolization. And now we're already talking about ablative radioembolization. So we're treating smaller lesions, segments of the liver, and sometimes a complete organ, and moving this patient into cure or liver transplant, which is also cure. So that new modality of CT acquisition is an add-on, and will make us speed up treatment and have more effective treatment. Now we have some questions from the audience. The first one is for you, Dr. Abath. Jose Augusto Bonzani wants to know if prostatic embolization can be used in confirmed cases of prostate cancer. I'm going to hand over that question to Carnival. He is our specialist in prostate here. Prostate embolization is approved and recognized in our country by the Federal Council of Medicine for benign prostatic hyperplasia, BPH. So prostate cancer usually has other therapies. We do have patients that have BPH, and during staging, during the evaluation, they developed a mild stage tumor, and after the evaluation by the urologist and radiotherapist and patient decision was to treat the symptoms, initial symptoms of BPH, which are dysuria, by using this technique. However, that was only done in select cases, very select cases, especially because this technique does not have scientific evidence for prostate cancer. Only efficacy and safety for BPH, which has been proven for over 10 years.